Again, it's my great pleasure to invite Dr. Kishore. Kishore was instrumental in doing a lot of initial research on Zeiss with his mentor Dan Reinstein. He's based in Nepal but trained in London. And he was also very instrumental in starting the ATOS human trials. After we did the first feasibility work with 20 patients, when they realized that it's doing well, the bigger part of it and all the R&D was done by Dr. Kishore. So Dr. Kishore.
Thank you so much, Dr. Ray. Thank you for the introduction. Good afternoon, everybody. My talk today, lenticular extraction with ATOS femtosecond laser by Schwinn. It is called SmartSight, and the post-op day one results a little bit. So in the past 5 years now, with the journey with the ATOS, the name of the procedure changed many times, and then it's called SmartSight now from Titan, and again it is being called Lelex or Relax or whatever. It's still changing. Probably one day we'll probably come with a better name for the lenticule. So with the ATOS now, the laser excellence, it is a very high frequency laser with about 4 megahertz, high speed, high numerical aperture, excellent resolution with quasi-telecentric optic. In a sense, the laser comes very close, the scanner comes very close to the cornea, and the cutting quality is the same in the center and in the periphery, in the front as well as the back. So lenticular tears and tags are not there. It is a semi-automated centering device in the patient eye, which includes the static cyclotorsion compensation, which can be imported from the Schwinn Cirrus Schemflix system, the MS39 OCT from the Paramis. It has pupil recognition with a objective treatment offset, cyclotorsion correction during and after the docking procedure. The eye tracker guided centration and docking, it provides a very robust, accurate, and a precise alignment of the eye to the system. The eye tracker guided asymmetric transition zone concept provides a robust, accurate, and a precise alignment of the lenticule to the eye. It's very important to differentiate two different things. The asymmetric transition zone, which works exactly like the MRS 1050 or MRS excimer laser system. So the lenticule is differently shaped. It is steeper in the center, like it is not parallel to the surface of the cornea, the upper cut. The lenticule edge is again designed differently. It goes rarely down to 0 microns, so it is thick in the center and thin in the periphery, going down to 0 microns with no minimal thickness and no side cuts. So this is just a concept showing you an asymmetrical transition zone so that you don't get an edge glare because of large angle kappas. So on the energy settings over here, we moved down. We did a study and we started from 120 nanojoules with 4 and 4 spot and track distances like any gold standard with the Visumax. And then over time we played around trying to reduce the pulse energy up to 80 nanojoules. And our spot and track distance was 6.5 and 2.5 as the track. We just cannot reduce the pulse energy because the dissection will get very tough, so you have to really play around with the spot and the track distances. So this is what it is right now. It is an in to outbound laser. That means it starts from the center to the periphery. At the beginning, we did have a lot of difficulties with a lot of OBLs, but later on, there's the software change. Things are very easy. It also has an advantage that when the patients are a little fidgety, most of the time it is at the end of the procedure, so any black spots or any slithers are at the periphery and not in the center. The lenticule goes to 0 microns, zero thickness right up to the edge, and has a large transition zone is about 0.8 millimeters. And corrections, I've done surgeries up to 30 microns. And I do advise most of the surgeons not to go below 30 microns. Sometimes you can get you can get a hole in the lenticule too. The profile of the transition zone, 0 thickness and the large transition makes this progressive and makes the lenticule aspheric. This is my current setting right now. So the most important thing, we've done a lot of work with spot, track, spot, as well as dose and power. We realized that the dose of the amount of dose that we put into the cornea is also very important. So right now, our average dose is about 440 millijoules per centimeter square. That is very, very little. That's so that the next day the corneas are really clear. We've done about more than 3,000 patients. This is just a simple video how the cyclotorsion and descent of more than 200 microns, inducing a lot of coma over here or even astigmatism. So this is the study over here. We did a study where we had two groups with high energy and low energy groups, and we also calculated the dose. We tried to keep the dose very, very low. So we have the group over here, which is important, is called the asymmetric group, the group A with asymmetric group with low energy. So immediately with low energies, we realized that our post-op visions day one with the low energy asymmetric group, 92% of our patients were 20/20 and 42% 20/16 day one. So if you look at that, this is my slide in 2022. We were still struggling, 82% 20/20 in 1 week. That is 2 years back. We were still very happy with this result, and now the results are much, much better. Let me skip these slides. What I'm trying to show over here is one line more or better. 40% of the patients are one line or better than their preoperative corrected distant visual acuity. The refractive corrections are the same with the group A and group S, that is a symmetrical group. But then again, what I'm trying to tell you here is the amount of swelling that you induce in the cornea is very important, that you induce astigmatism, the haziness, or sometimes the patients also say there is some amount of smokiness. When is it going to go? That really reduces. The wow factor has actually increased to about 90%. So even the induced astigmatism day one is 100% of the patients are within 0.5 diopters of astigmatism day one. So in conclusion, I would say ATOS is doing very, very well. We've done very well in the past 5 years. It has been evolving very fast. Now that there's also from cap to flap software is there, and only side cuts, the only side cut software is also there. The rings and the keratoplasty are to be out by September. And probably by next year, the customized lenticules will start. Thank you so much.
Samit, can you just keep his slides on, please? We have a few minutes because we have, I don't think Shadi about the presentation has been uploaded. So there are a few things which Kishore is very good at, so we should discuss with him about, is it possible to go back to the slide where you put all the energy settings, where you reduced and changed its spot size and all that? I'm sure that because of the time, this is very difficult. These are all things which the previous one, yes. So this is very important slide, which I think anybody who is getting into the dynamics of lenticule procedures should be aware. Forget about the numbers. Every machine has a different fingerprints, and all the machines behave differently in Nepal with the temperature, with the humidity, compared to Bangalore, Goa, everywhere it may be different. So this is something which you have to sit with your engineers, do every case, and start adjusting. So anybody who wants to start, it's not like LASIK. I've done thousands and millions of LASIK surgeries. I just go take a VIP patient into my OR and I finish my surgery. It doesn't work that way. you need a little bit of patience, because every machine has to, for example, what is doing is spots is when, Kishore, you can also pitch in and discuss here, because we have few more minutes where we have buffer time to discuss. Spots is between, every time a laser fires one spot, how much is the distance between one and the second spot? So when he says 4 microns, it means 4 microns, the second spot will fire at 4 microns, and he has now reduced it to 6 microns. That is the distance between this and the second spot. So what laser machine does is it fires the first spot, the second spot is firing at 6.5 microns. That's a distance. Track is between this spot and what happens on the top or down. So he has kept it as initially started at 4 microns, now it's reduced to 2.3. When you do that, if the spots are coming closer, so what happens is sometimes you have to make sure that your energy also have to reduce. In this case, he's trying to balance it. That means if spots are coming closer to each other, that's what Professor Maipal said, every spots fall next to each other. But what J&J has done is they don't fall on each other, they just make sure that the spots, that's why the aperture and how the dimension of optics is very important. And this is very important for us to understand is because this is exactly like how you do a phaco. If you understand the phaco dynamics, the skill comes very easily, effortlessly. So if your spots are falling on each other, then what you have a multiple OBLs, you don't. If your spot are too away, if the distance is too away, that's what Kishore said, that if it's too away from the first spot, that area becomes a black spot, and that's when you cut it. So what you have to do is, you have to optimally in such a way that you adjust that, your spots and your line and your energy. That means if it comes too close, I have to reduce the energy, because if I have to come too close, the spots form on each other. And that's when you increase the cumulative energy. And this is a very beautiful thing which Kishore has brought out. No, Kishore, the other one, the calculation. So if you can explain this in a very quick way, because this is important, because the spot and the line and how this is relation. For example, if I keep too many spots very close to each other, the machine takes a longer time to do the procedure, because you need multiple spots to be put to correct it. But if you keep it farther away, the machine becomes faster, because you just need, instead of 10 spots here, it just needs 1 and 1 here. That's how you work on the duration of the lasers. This is important one for everybody, which Kishore can explain on this.
This slide over here is putting in the dose actually over here. So I did a live surgery in Bangalore recently, and Dr. Pooja was there with me in the OT. Even there, we just a little sticky lenticule, and we just played around a little bit with the track, and then it was so much smoother. And actually what the dose is very, very important. Is the amount of total energy that you're putting into the cornea is very important. It's very simple. You can take your mobile phone and just calculate the spot, the pulse energy divided by the spot distance divided by the track distance multiplied by 100 is the amount of dose that you really get. So sometimes we think that you're really reducing your pulse energy, but then at the end you'll end up putting more energy into the cornea. So this is so important to just understand the formula of this dose. It's very, very simple. I always calculate most of the time. Sometimes I'm playing around all the time with this energy, and then I realize that the more dose that you put into the cornea, the worse is the result the next day. So right now, I think the best sweet spot to play around with is around 600 nanojoules per centimeter square. That is where you get the best results. I think you should not go very, very low down also. You can go down to, this is where 440 is where I'm working at, but at the beginning I think you should always start with around 600, 650.
So tomorrow, wherever, in whichever part of the world, when people talk about the energy, spot distance and track distance, just remember what it is. The spots and the track is the track which makes those spiral or raster patterns. And every company has their own way of how they have balanced that track and energy thing. And that is sometimes, like for example, we realized in the recent meeting that the Schwinn and the Zeiss work on the cumulative energies, and Zimmer and the J&J work on a different different way of how they look at the energy system. But this is a basic foundation of this. That's the second question quickly, if you could answer, is what do you mean by asymmetric transition zone?
All right. The asymmetric transition zone is, again, the lenticule sometimes with the ATOS could look a little oval. So what it actually does is, when you take the scans from the topographer and then we put it into the ATOS, you don't actually have to mark the cornea or anything, because the laser itself knows that there's an angle kappa, and if the lenticule is decentered on the, you put the lenticule on the vertex and it's decentered from the center of the pupil. So sometimes when the pupil dilates in the mesopic pupils, you can get a lot of edge glare. So the asymmetric lenticule is the transition zone becomes slightly bigger on the place where it has moved away from. For example, that over there, you can see the lenticule might become a little oval, trying to cover up for the edge glare at night.
It's very important because the next generation lenticule procedures are not going to be plano and convex or just plano. Next generation lenticules are going to be more unforgiving because they have a different shape, like what he said. So if your aspheric design of your lenticule moves away from your vertex, you might get a more challenging things than what we would see probably with Zeiss, because it has a different profile. Every lenticule has a different profile. It has its advantages, and it also comes with a lot of challenges. And what he said is that it's trying to balance this decentration by adding this asymmetric.
The transition becomes a little more on the other
Any
side.
other questions on this particular subject? This is nothing to do with ATOS. This is just about, yes sir, this is about anything to do with lenticule procedures.
The profile, it is an aspheric.
That means that the lenticule becomes slightly ovalized.
Yes.
So doesn't this change the entire profile of the lenticule?
Not really, but this is already calculated with the software and things. It doesn't induce astigmatism or anything like that.
And
Like
this
in the
is,
profile in the sense, like, are you trying to say it is?
so the convex kind of structure, it begins from the center, from the pupillary center, and then goes to the periphery.
Periphery,
right?
it goes down to 0 microns.
Exactly. So
Yes,
once
it is exactly like that.
So once it's ovalized, so the center remains where, the docking initially had, and then once you reach the periphery, the centration is not right, the apex of the lenticule is not right at the place there.
No, it is there. The apex of the lenticule will be exactly on the vertex. It's just the periphery.
Center shape does not change.
No,
it just
center-
balances the periphery in a way that you don't get a decentered edge one, because now you have more of a convex shapes. So the center doesn't change.
But then it becomes a little ovalized.
It's more in the periphery. And that's
That's
exactly...
not too much. It's like when you look into the topographies, it will not look like it's like a decentered or like a something else. It's
This
just
is
for your
actually
edge
used
glare.
in, Kishore would agree, this is actually used in the laser profiling also.
So it's just for your edge glare only. It doesn't look like, oh, tomorrow your corneal topographies look totally decentered. Nothing like that.